Welcome back to another neonatology lesson, everyone. In today's lesson, I will talk about polycythemia in neonates. Neonatal polycythemia is defined as a central hemoglobin or hematocrit exceeding 2 standard deviations above the normal value for gestational and postnatal age. A full-term infant is therefore considered to have polycythemia when the hemoglobin concentration is more than or equal to 22 grams per deciliter or hematocrit is greater than or equal to 65%. Measuring the central hemoglobin using an automated blade counter is very important because both peripheral and capillary tube microcentrifugation yield higher hematocrit values than central values by up to 50%. Etiologies of neonatal polycythemia are numerous, but can be grouped into two broad categories. Those are passive RBC transfusion into the fetus and increased intrauterine erythropoiesis. The cause of passive fetal RBC transfusion include delayed clamping of the umbilical cord, which is the most common one, twin-twin transfusion for the recipient, and rarely maternal fetal transfusions. Neonatal polycythemia, secondary to increased fetal erythropoiesis, has many causes, including post-maturity, SGA and also LGA, and infants of diabetic mothers, infants with trisomy 13, 18, and 21, adrenogenital syndromes, neonatal Graves' disease, hypothyroidism, infants of hypertensive mothers or those taking propranolol, and Beckwith-Wiedemann syndrome. When we see say, signs and symptoms of polycythemia, signs and symptoms can result from either hyperviscosity or metabolic disturbance or both. Most polycythemic infants are overall asymptomatic, and in those who are symptomatic, symptoms often appear in the first few hours of life, but can be delayed up to 2 to 3 days. Symptoms include, which are non-specific, irritability, lethargy, tachypnea, respiratory distress, cyanosis, feeding disturbance, jaundice, hypoglycemia, and thrombocytopenia. Severe complications include seizures, stroke, pulmonary hypertension, necrotizing enterocolits, renal vein thrombosis, and renal failure. Because most infants are asymptomatic and these symptoms overlap with many neonatal conditions, other respiratory, cardiovascular, and neurologic disease should be ruled out. Dehydration should always be considered as a cause. And hyperviscosity in infants might be accentuated because neonatal RBCs are large and have decreased deformability, which together predispose to stasis in the microcirculation. Management of polycythemia depends on both the level of hematocrit and whether the baby is asymptomatic or not. In asymptomatic babies with venous hematocrit between 65 to 70, always first we should have to increase fluid intake by 10 to 20 ml per kg per day and repeat hematocrit after 6 hours. Partial exchange transfusion is indicated for symptomatic patients with venous hematocrit more than 65% and peripheral venous hematocrit more than 70%, even in the absence of symptoms. Partial volume exchange transfusion is done by withdrawing blood from umbilical vein and replacing with normal saline using the following formula. The volume of exchange in ml is equal to blood volume of the newborn, which is around 85 ml per kg, times observed hematocrit minus desired hematocrit, which is around 55%, divided by observed hematocrit. For example, if the neonate is weighing 3 kg and its hematocrit is 75%, we calculate the volume of exchange in ml, 85 times 3, which is the weight of the baby, in bracket times 75 minus 55 divided by 75. This comes around 68 ml. So 68 ml of blood is exchanged with equal amount of normal saline. And after the procedure, we should have to determine post-transfusion after 4 to 6 hours. And during the procedure, and 4 hours before and 4 hours after the procedure, we should have to keep the baby NPO to prevent the development of necrotizing enterocolites and put the baby on maintenance fluid. And also, we should have to do random blood sugar every 2 to 4 hours for the first 24 hours after the procedure to detect hypoglycemia early and intervene. This is all about neonatal polycythemia. Thank you for watching.